Good afternoon, everyone. I'm Dr. Janice October, and this afternoon I'm presenting Dr. Norbert Skokauskas, who is a professor of Child and Adolescent Psychiatry and chair for research at the Center for Child and Adolescent Mental Health and Child Protection, Institute of Psychiatry at the Norwegian University of Science and Technology, Norway. Professor Norbert Skokauskas is also the chair of the World Psychiatric Association Child and Adolescent Psychiatry section and the editor of the World Child and Adolescent Psychiatry. Thank you.
Hello, my name is Professor Norbert Skokauskas, and I'm the chair of the WPA, World Psychiatric Association, Child and Adolescent Psychiatry section. I'm also a professor of Child and Adolescent Psychiatry at the NTNU, the largest university in Norway. It's a great pleasure to be with you today. And of course, the pleasure would be even greater if we had the opportunity to meet in person, face to face. Unfortunately, this is not possible at this point in time. But I really hope, I really believe that in 2022, we have an opportunity to meet in person and to talk about the issues and to have a discussion and to learn from each other. So this lecture is my first lecture, is like introductory lecture. And I hope once again, there will be an in-person meeting in 2022. I was asked to speak about the mhGAP. mhGAP is the WHO World Health Organization product. I need to say that at present, I have no formal relationship with the WHO. I do not represent the WHO, and I do not work for the WHO. At the same time, I have great experience collaborating with the WHO. In fact, in 2018, I lived in Geneva, Switzerland, and worked as a consultant for the WHO, focusing specifically on the mhGAP pre-service training. So what is mhGAP pre-service training? Well, first, mhGAP was introduced as in-service training. In-service training is that you train the people who are already in service, but they lack some of new skills which are needed at that point in time. So for example, you have primary practitioners which perhaps haven't got proper training about mental health disorders, and then they attend several days courses in mhGAP, and then they are empowered to provide the better service for people who have mental health needs. So this is in-service training, when you take out of service people for several days and train them. Now, my focus was on pre-service training. Pre-service mhGAP training is where you work with the young people who are still not in service, who are still in training. And my focus was on introducing mhGAP in pre-service training, more specifically in medical doctors training, nurses training, and so far so on. Because pre-service training is more sustainable once you introduce mhGAP into curricula. You don't need to get extra resources to organize those short meetings. You don't need to take people from their in-service, very important positions. You can just go on with the pre-service training as long as you need. I will speak about this a little bit later. I also want to say that while my presentation is called mhGAP, I want to have a little bit wider overview. In fact, the question which I am asking everyone in this lecture is Child and Adolescent Mental Health Services, how to meet the current needs, current challenges. Because mhGAP is one of the solutions, but it's not solution to everything. Moreover, mhGAP is a concept and it needs to be adjusted and adapted to the current needs of your country, your town, your clinic. In that sense, I think if you decide to use mhGAP and collaborate with the WHO, with your regional WHO advisors, it's also very important that you get familiar with the mhGAP and see what resources you can dedicate to the training, what expertise you have and what expertise you need to develop. And also look at other innovative solutions which goes above mhGAP, which are needed in your settings. So this is a picture of my university. As I already mentioned, I am based in Norway, and this is the largest university in Norway, NTNU. I don't think my university has any formal collaboration with the Guyana or University of Guyana. And this is the downtown and also hospital setting, which you can see from this picture. It's very green and blue. But as the matter of the fact, in most days, in winter, it's very white because we have plenty of snow. Before we start into nitty-gritty, it's important to remember and emphasize that mental disorders are common. Mental disorders in child adolescents are very common. Depending on the study you look, it's 1 out of 3, in some papers, 1 out of 4 face mental disorder across their lifetimes. In addition to being common, the mental disorders, they cause massive disabilities. Here is in comparison mental behavioral disorders to other disorders. As you can see, mental behavioral disorders take up to 20% of years of life lost to disability. And this is just a summary of the terms for some of us who perhaps have never heard about these terms, or maybe just forgotten them for a moment. And the impact is largest in the young people. As you can see from this slide, it's the 15 to 19, 20 to 24, and 29 who suffers the most. I don't want to give a negative message. So while the child and adolescent, while the childhood and adolescent is are very vulnerable stages of life, at the same time, they are also the stages where possibilities or opportunities to intervene and to help are massive. I remember when I was a junior doctor, I started my career in psychiatry, in general psychiatry. And I still remember one patient who came to me. He was a middle-aged man, and he said, "Dr. Norbert, I have heard so many good things about you, and I truly believe you will help me." And then when this patient was new to me, but he obviously was not new to the service. So when I looked at his notes, there were maybe so many old notes. He had many problems and almost all medications have been tried. Of course, it's impossible. Of course, it's possible, but it's not easy to make a very big change for such patient in a short amount of time. However, when you have a child patient, even adolescent, most of the time you have, so you can see I'm showing just empty sheet of paper, 1 page. You just start writing your case history, and this is the first lines you are putting, which means if we intervene early and we use mhGAP or any other strategies to help those children, we really can make a difference. So childhood and adolescent, of course, it's a stage where there are many risks, but as you can see from this table or this picture, there are also many opportunities to make sure that the child gets better and has opportunity to go to school and to benefit from developing friendship. Because again, one more time, we all know when the child is sick, he's deprived those very important events in his life, very important experiences like learning, also developing social skills, developing friendship, getting boyfriends and girlfriends when somebody becomes teenager, and so far, so on. We also need to remember that the child psychiatry as a field, or the child mental health as a field, is in a stage of change. Maybe for colleagues in Guyana who are just developing child psychiatry, I think there are maybe 2 or 3 child psychiatrists. Maybe that's an opportunity for you because you can learn from our mistakes and you can develop new field in your country, which is fresh and which takes what is best from other countries and does not repeat our mistakes. Things which we need to consider when we talk about mhGAP or any other innovations in the child psychiatry, there are things which need to consider. First, there is a universal greater demand for the services. I can remember from my practice, let's say 10 or 15 years ago, it's a completely different situation then and now. And there are many reasons why the demands are greater. For example, in Western Europe, the stigma related to the mental health, it's much, much smaller than it was 5 or even, a couple of years ago, which is good. But it also means that, some issues which were dealt at school or within the family circle, now it's very easy get referred to the specialist service, and we get more and more patients. We also know that the young people, adolescents, young adults, they're very easy, or they're very quick to check everything on internet. And if they check on internet and they get criteria for depression, they are not shy to speak about it. And this is very good, don't get me wrong. But the fact is that the services in many places were not ready for the greater demand. So we have to innovate. We have to think how we can provide the services when the demands are greater and resources are the same or even smaller. And again, mhGAP could be one of the answers to these particular challenges. There's another change which is related to the classification. As you know, ICD-11 was introduced in 2018, and now through the upcoming years, it will be gradually or is gradually introduced in many countries. Now, why it's important to speak about the ICD-11 or other category? Because depending on your ICD-10 code, you get access to certain services, to certain treatments and certain interventions or not. And depending on the changes, your situation could also change. So this is things which I would like to talk about too. There are changes in management. We can perhaps dedicate a separate lecture on that. And there's also the lack of staff. I think this is also a very universal challenge. And I think we are not very good at attracting medical students to child psychiatry, because many of them would like to be the real doctors, somebody who operates and perhaps does not engage in very lengthy conversation with the families and children. At the same time, we have to acknowledge that there are also reasons which are outside of our influence zone. For example, I remember very vivid one situation when, as a young doctor, I spent almost 6 months in Boston at Boston Children's Hospital. And I remember one student who did a summer placement, like elective, in Boston Children's Hospital, elective was focusing on the child psychiatry. She was very good, she was very passionate, she was very professional. And I remember asking her, so I have no doubt you will choose child psychiatry as your specialty. And she said to me, no, I am very passionate about child psychiatry, but I also have student loans and dermatology just pays better. So, we lost somebody who perhaps would be very good for the child psychiatry. In this case, I think it's quite universal. It's not only in Boston, these things happen all over the world. Another thing which we also have to realize that the families are playing more and more important role. Even a decade ago, or definitely 15 years ago, when the patient came to me, the family did not have much information about the ADHD or autism, but now everybody Googles before he or she sees the doctor. And when the family comes to you or your colleague, in many cases, they already have diagnosis in their mind. So in that sense, the medical providers, the health providers are no longer monopolists. They don't have the monopoly of knowledge. Knowledge has no borders, especially these days. And in that sense, we are becoming facilitators. We need to address families' concerns based perhaps not on the best, sometimes even misleading information from the internet. On the other hand, we also have to understand that the families, they have nowadays much more knowledge about the many disorders, including mental disorders, due to the fact that this information is readily available. Accessibility is also a challenge, because if you live in the big city, your chances to get access to the specialist are much, much greater than you live in the province. And then in the rural settings, the role of the interventions like mhGAP becomes even more important, because in these settings where you have no specialist or very few specialists, you really need to have something which empowers non-specialists to provide services, and mhGAP could be an answer, one of the answers. Universal healthcare. I'm sure everybody has heard Dr. Tedros' universal healthcare agenda, where he says, and many other people say that access to health is a right and not a privilege. And another thing which is very important to emphasize, that when we provide the large coverage of services, when we provide, for example, mental health services by non-professionals using, again, mhGAP, it's very important that the quality of care does not diminish. In fact, some opponents of the mhGAP, in some countries, there was strong opposition to mhGAP from psychiatrists who said, well, why we would use mhGAP instead of the well-qualified psychiatrists. So psychiatrists spend years and years of training to become a psychiatrist, and then mhGAP provides the training for the people in a few days. And how can we not be concerned about the quality? And the answer to this, we have to recognize that mhGAP is not a supplement for the psychiatry training. mhGAP provides just a core training. In fact, it helps psychiatrists because mhGAP trained people can deal with the very simple, straightforward problems. But if there are more sophisticated problems, of course, they have to be addressed by psychiatrists who are trained for many years and know much more about mental disorders and their management than someone who is trained in mhGAP. And I already spoke about the COVID, and I'm sure you would hear more about COVID because COVID also contributes to greater demands. Children staying at home, parents working remotely, all this in many countries around the globe contributes to a larger stress. So this picture illustrates the greater needs for the child psychiatrists around the globe, and the child psychiatrists in the dark green, and that also applies to your WHO region. This is the slide which a little bit goes to the side, so to speak, but I would like to mention that the WPA, our section, has established 3 consortiums which assessed the needs and the training needs for the child psychiatry in Southeast Europe, Middle East, and Far East. These consortiums, they provided information how little training or how little capacity of the child psychiatry training is around, and also made some suggestions how to overcome those gaps using mhGAP, but also using other possible solutions. So as you can see, South America is not in the loop, but if I have a chance to meet at least some of you in person, there's something we can also discuss about. And of course, these are only a few papers, and now we have many more papers from these 3 consortiums. Now, as I said, in many places, access to the services, access to the help, access to the care depends what diagnosis you have. And let's just briefly mention some changes which are happening with the ICD-11 now. So you all know that DSM is coming from USA, but the rest of the world, we have to use ICD because it's the WHO, World Health Organization system, and World Organization is a part of the United Nations system. So I already mentioned that the ICD-11 was introduced in summer 2018, and now gradually it has been implemented through the world. And the focus in ICD-11 is on clinical utility and the collaboration with stakeholders, health professionals, service users, and families. There was a need to revise ICD-10 because the science has advanced, and there are also new demands, which we spoke about already. The technology over the last 20 years has advanced quite a lot, and there is also need to capture more information. And there's also quite an important comorbidity issue, because in medicine we deal with disease, but in psychiatry or mental health disorders or mental health, we deal more with disorders, for example, ADHD, attention hyperactivity disorder, or autism spectrum disorder. And disease is a defined pathological process having a characteristic set of signs and symptoms. However, disorder is the arrangement of abnormality of function. So some people, in fact, Michael Rutter, who left us some weeks ago, unfortunately, the first professor of child psychiatry in the UK, he suggested to use the terms co-occurrence, which is more neutral. And in child psychiatry, we especially meet many children who have not one disorder, but several disorders, two or sometimes even more. And how do we address those challenges? How do we provide the best possible treatment for the child and the family? It's the question which needs to be answered. So just to summarize that, co-occurrence is a common phenomenon, not always well understood, and it has impact on service provision and quality of care. In fact, Professor Norman Sartorius, who is also, I believe, on this program, he has designated lectures on comorbidity, so I hope he will extend on this in his lecture even more. Now, ICD-11 comes with improved usability, more clinical details with less training time, and as I said, reflects the scientific changes and also provides electronic platform. Just few changes I would like to mention. So ICD-10 did not have ADHD. It had hyperkinetic disorder. And now ADHD has been moved to neurodevelopmental disorders group. Autism, as you know, in DSM-4, we had autism, Asperger's syndrome, and also PDD-NOS, pervasive developmental disorder, non-otherwise specified, which DSM-5 just has autism spectrum disorder, and ICD-11 also goes from several categories into a single category of autism spectrum disorder. Gaming disorder, another topic which is new to ICD-11, and fewer diagnostic terms for PTSD are also a feature of ICD-11. And also we know that some disorders, for example, gender incongruence disorder, was taken out from ICD-11. So this is a picture from Norway. This is a place called Lofoten, and it's in northern Norway. And I think it's the most beautiful place in Norway. So I wanted to share this picture with you. So now coming back to solutions, because we spoke about the problems. And as I said, we need to develop new approaches to the services. And we need to innovate. And mhGAP is innovation, innovative approach, but of course, not the only one. So innovation is a combination of activities or technologies that breaks existing performance trade-offs in attainment of outcome in a manner that expands the realm of the possible. In other words, how to get more for less. Well, Of course, mhGAP is not the first innovation in mental health. There have been many more in the past and at present. And if we were in person, perhaps we could have a discussion about the innovations in psychiatry in your setting. But now I think we need to all emphasize and agree that the digital mental health landscape is changing. Excuse me. We have mobile interventions, many ECBT and other mobile interventions which are changing the landscape. And we also have new opportunity of digital phenotyping and care management who really can change the practice everywhere. Because these days, I think in every country, especially young people, have mobile phones and in fact cannot imagine their life without mobile phone. And mobile phone also collects a lot of information on us, which can also be used for the purpose of diagnosing and later mental health or other service provision. And I also wanted to say that this picture is not mine. I took it from Strong Mind. I'm not going to go in details into digital phenotyping, but this is a very interesting example. So I think most of you who are in the mental health, you are familiar with the trial-making test. This is test which is not coming from the child psychiatry. It's from adult and old age psychiatry. But these movements where you have to connect the dots, actually these movements we do every day when we search information and we work on our phones. So in that sense, the trial making test, actually it's already in our phone. We have done this test despite we wanted or didn't want or did not intend to do it. We just have to get it from our phone, this information which can be tested. Or maybe somebody is already testing it in the cloud. So there are many digital innovations, but regardless, is it digital innovation or mhGAP innovation, which now also coming to digital, it's very important that we have the consent of the key stakeholders. So we have physician on board, we have patients, we have organization, we have the companies which help us to do it, and of course the government. So if you think about the mhGAP or any other innovative tool, there is a lot of work which needs to be done before the implementation of mhGAP or any other innovative tool. I just would like to mention very briefly my experience with other innovative solutions which I have used in my practices. So we developed the ECBT for children and adolescents with obsessive developmental disorders, which have been now tested and published papers on this, and it's a smartphone application, psychoeducation video and video calls. And there's also one system, new system which we introduced, which use the big data, also clinical guidelines to support decision of clinicians. In other words, when I was a young doctor, and if I didn't know what to do with a patient because it was very complicated, I would go and ask more experienced doctor and I say, I have a Peter and he these and these symptoms. Have you had similar presentations? Have you had similar patients? And what have you done with them? And the old doctor would say, oh yes, 25 years ago or 15 years ago, I have these such and such patient who I prescribed this and this, and then he got better or get worse and so far, so on. So in this sense, nowadays we can use the big data to ask all these questions. And while maybe in some countries this big data approach seems so far away, I think it's very important that when we plan service, that we plan new services, that we get the data right, that in the future, on the near future, we can avail of the data which was collected on the patients, and that data can support our clinicians in the near future. So the mhGAP intervention guide, it's a package. So we have the app, we have operational management, operation manual, and also training package. mhGAP intervention guide has been used in many countries, and it has been translated to many languages. And there is a competency-based training and assessment approach which facilitates cascade model of training. So we have master training, we have a trainer, and then the trainer trains the health providers. There are several modules, and child adolescent psychiatry or child adolescent mental health and behavioral disorders is one of the modules. All this information is readily available on the WHO website. And as I said, the child adolescent mental and behavioral disorders, they have their own module. Now, my time, when I was a consultant to the WHO, I focused specifically on the pre-service training. I already explained what is pre-service training for the mhGAP intervention guide. And the recommendations I prepared together with my colleagues, they are available on the website, on the WHO website. So please visit it and read it. I have to say that these recommendations came together after several consultation sessions. And as you can see here, Christina Horn was also included in those consultations. And this is actually the session from the WPA World Congress, which was held in 2018 in Mexico City. The potential benefits of pre-service mhGAP training is lower cost and increased returns on investment by leveraging both limited training resources and a captive student audience. Overcomes the barriers of high staff turnover that underterms in-service training, and mainstreaming of mental health care and its acceptance as core skills. There is no one exclusive specialty which is best suited for mhGAP pre-service training. It can be used for medical students training, public mental health master's programs, nurses, psychologists, social workers, and allied professions. And this is one more time, it's the WHO website and the recommendations and also experience from implementing of mhGAP pre-service training, which are summarized in this document, Enhancing Mental Health Pre-Service Training with mhGAP Intervention Guide, Experience and Lessons Learned. My time is coming to the end, and I would like to summarize what I have said. First, we are facing many challenges in the child and adolescent psychiatry field, especially these days when the profession is in the stage of the change. Profession and the field of the child and adolescent mental health. In order to be successful, we need to be innovative. That's number two. Number three, there are many ways to be innovative, and mhGAP is an innovative approach which is promoted and created by the WHO. And lastly, I really think that mhGAP pre-service training is a very good way to address the challenges which we have discussed today. I thank you for your attention and wish a very fruitful and enjoyable conference. See you in Guyana next time. Goodbye.